The first question you might be asking yourself is, why is there a kid at my forward surgical team or combat sport hospital? That's an issue, and why this podcast topic is important, because our doctrine has always said we don't take care of kids. We're not supplied for kids. We're not staffed for kids. And every deployment, we are taking care of a bunch of kids.
The whole adage of children are just little adults. When it comes to trauma care, keeping it simple and relying on those standard principles.
Enter the world of military trauma surgery with Frontline Surgery, where we bring you expert insights and real-world scenarios to help surgeons stay ready.
Brought to you by the AAST Military Committee. Join us as we engage in conversations with field experts, examine critical battlefield scenarios, and uncover the strategies that keep surgeons ready for anything.
Stay prepared and stay sharp with Frontline Surgery, where every episode provides key insights into mastering military trauma care.
Welcome to Frontline Surgery, Mastering Military Trauma Care. I'm Jeff Conner, an Army trauma surgeon.
And I'm Jay Yelon, a Navy trauma surgeon.
In this series, we help prepare early career military surgeons for the realities of deployed trauma care, sharing key insights from those who've been there. Today's episode is a very important one, focusing on pediatric surgery and trauma care in the deployed setting. We're honored to be joined by Dr. Luke Neff, a pediatric surgeon and former U.S. Air Force staff surgeon with deployment experience in supporting Operation Enduring Freedom during 2013 and 2014. We're also joined by Dr. Matt Martin, a current trauma surgeon at L.A. County and retired U.S. Army colonel with extensive deployment experience over his career. Thanks for coming, everybody. So let's start with a scenario. So you're at a Role 2 in an urban region of Eastern Europe. You're supporting both U.S. forces and a local national population. And a 7-year-old boy presents after blast injuries. There was reported hypotension in the field, and he presents with no vascular access. On arrival, he has an obvious mangled right lower extremity and evidence of shrapnel penetration on the extremities and torso. Dr. Neff, Dr. Martin, you lived through scenarios like this before. What's going through your mind as the patient rolls through the door?
Where's the Broslow tape? That's certainly number one. Do we have the stuff we need to resuscitate this kid? So thinking through access, thinking through hemorrhage control with tourniquets and things like that, which are fine to use, I think a general principle, and I'd welcome Dr. Martin's thoughts on this, but, the whole adage, depends on who you ask, the whole adage of children are just little adults. I think when it comes to trauma care, keeping it simple and relying on those standard principles that you would follow for ATLS or deployed combat care downrange are the same, whether it's a child or an adult, with some caveats. But I'm certainly thinking about Broslow tape, though, specifically with medication dosages and things like that.
Yeah, the first question you might be asking yourself is, why is there a kid at my forward surgical team or combat sport hospital, right? And that's an issue, and why this podcast topic is important, because our doctrine has always said we don't take care of kids. We're not supplied for kids. We're not staffed for kids. And every deployment, we are taking care of a bunch of kids. And the papers written on it showed like up to 15 to 20% of bed days were pediatric patients in Iraq and Afghanistan. So that's the first thing. You're told it's not part of your mission, but it will be part of your mission. So I agree with Luke. The Broslow tape, but what that means is somebody hand carried that in, and then also hand carried pediatric supplies in. And that's what happened in Iraq and Afghanistan. We were there for 20 years and people were able to hand carry stuff in, and we had pretty decently developed pediatric carts, but we certainly didn't at the beginning of those wars. So bring pediatric supplies, bring a Broslow tape. It's a lifesaver. Have either a bag or a cart that's color-coded, just like the Broslow tape, because, again, Luke is a pediatric surgeon. You will not have a pediatric surgeon with you, most likely, or a pediatric nurse or a pediatric intensivist. So, and anything you can have to make your life easier. And for this kid, this isn't that different than an adult. You focus on hemorrhage control first, IV access, which most likely, unless there was an easy peripheral, would be an intraosseous in this kid to start your resuscitation.
I think that's one of the things that causes me a lot of heartburn, even in our civilian trauma populations, is that we are just not as willing to pull the trigger on intraosseous access, particularly for a child that's not obtunded, right? That can feel and is responsive. We don't do that as much, and I think we need that. That's a skill for anybody going down range. Being comfortable with that and learning how to use the Easy IO, I think, is a really important thing.
Some of the stuff both of you just talked about, and I really appreciate those comments. Let me tell you about an experience that I had when I was deployed in 2019. I was part of a far forward Navy single surgeon team. Most of our stuff was in support of special operations, and we were tasked to support a combined task force in which, right before the mission went off, we had some human intelligence that there were several children in the area where special operations would be. And as Matt alluded to, there is no doctrine talking about children, there's no equipment. So how do you prepare your team? Let's say you either packed a small bag of pediatric supplies, or maybe you don't have any pediatric supplies. How do you pivot in that situation to prepare to deal with that? And I'm gonna ask Matt to comment first, and then Luke, if you could follow up.
Yeah, I'd say one, you look at your resources and who you have, and even though we say, you don't have a pediatric intensivist or maybe even pediatric surgeon with you, as general surgeons, pediatric was part of our training. Your anesthesia people, they've done pediatric anesthesia, so there's some experience of familiarity there. The other part is just like we do with adults all the time is you have to improvise, right? You might not have a pediatric sized chest tubes, but you have, central line kits or drains or even NG tubes. So you have tubes and things that can be put into places that they weren't meant to. And more so with pediatric patients, a lot of times you're improvising and you're using something that wasn't necessarily made for that. I had to do an emergent pericardial drain in a 3-year-old with a massive effusion and tamponade, and all we had were central line kits. So I used a cordis kit, and it worked well. But you need to be prepared either to start supplying yourself or to improvise.
So you're advocating the idea of thinking critically in a time dependent fashion. Luke, you want to follow?
I think those comments are great. I mean, so much of what we do is, there's so many variations in size and situations that we do a lot of MacGyvering in pediatric surgery, and even more so downrange. As Colonel Martin was talking, I was thinking about this Navy SEAL medic that was talking about his suction. He takes a 60 cc syringe and some tubing, and that's his way of delivering fluids. It's also his way of creating suction. Like he just found 10 different uses for this piece of plastic. And so I think about Dr. Martin's comments about every instrument's every instrument. You can apply it in a lot of different ways. The one thing I would say that needs to be really thought through is, having the right IO access, because that's something that will not necessarily be a one size fits all situation. But also, one thing I think is really critical to think about with respect to children, especially, is gastric decompression. And I'm talking about in the acute moment because, if it's ABC or CAB or whatever you're working through to resuscitate that patient, you will have a can't oxygenate, can't ventilate situation on your hands really quickly when you're bagging a child. And a lot of that starts with, you may have the greatest oral airway and you may have an airway that you can maintain for a while. But once you start getting gastric distension, if you can't decompress that stomach, you're going to quickly get into a can't ventilate situation, and then ultimately can't oxygenate, etc. So I would say that for, the one message I really want to leave with people is do not neglect gastric distension in a child as a cause for can't ventilate, can't oxygenate. And even after you have them intubated with secured ET tube, if you happen to have one, if that stomach is still massively distended, you're not going to have your functional residual capacity and you won't be able to ventilate that child well. So that's kind of one of those things that was just amongst the issues of access and initial resuscitation and airway management. You got to think about the stomach in these small kids. That's maybe not intuitive to people, and that's something that you like to consider.
So speaking on vascular access, I mean, like you guys alluded to earlier, it's a common problem in the civilian setting, the deployed setting. We talked about IOs. What about central access? We're going to talk about here shortly about blood product resuscitation and damage control resuscitation pediatrics, but do we need central access? Do we need, you mentioned IO. What are some other techniques for getting good access with pediatric patients?
Luke, what would be your go-to central access?
Yeah, I think no matter what you're putting in, yeah, it needs to be, you can use a lot of different things. You can use a big 14 or 16 gauge angiocath. But the one thing I would say is ultrasound is so key in these kids, especially if you have a hypovolemic child. You're trying to hit a bullseye that's maybe at best 5 millimeters in diameter if you're thinking about the IJ or the femoral vein or something like that. Saphenous is a great thing if you have the time, but those are a lot smaller. Like a saphenous cut down in a small child is really difficult. The one thing I would say is part of your quote unquote kit is the 5 French micropuncture kits that come with the 018 floppy tip guide wire and the 21 gauge micropuncture needle. That is nearly ubiquitous in terms of vascular access for vascular surgery indications. But the things that make it better than anything you would get out of a kit, a central line kit, is the fact that the 21 gauge needle is ultra sharp, and it usually has a radio or an ultrasound kind of lucent tip that you can really see well in ultrasound. And that floppy tip guide wire is really helpful. And once you get that 5 French sheath in, you pull the stylet and you can do anything you want in terms of getting access, or you can just leave that in and that's your thing. So I would say, if I'm packing to go somewhere, I'm making sure I have a range of the IO stuff, some nasogastric tubes that could double as chest tubes, etc., and then micropuncture access, because then you can do a lot of stuff. And so what if you've got 4 centimeters of a standard adult central line in a child, or whatever you need? So what, right? At least you've got the access. But that 5 French micropuncture set really helps you. It sets you up for success.
Yeah, we had a stack of the pediatric IJ kits, and those were great for central lines in essentially any age, and femoral and actually subclavian, especially for the 1-year-old or under that we couldn't get anything. But that was kind of our go-to. But those are challenging lines to get.
The other thing I would say too, if you're just thinking about this or thinking through and listening to this podcast, is I routinely, especially as it comes to IJ and femoral access, I will not have a syringe on the needle. You've got one shot at this. And so if you're doing ultrasound guidance or even blind using landmarks, when you get any semblance of flash, that's the time for the threading of the micropuncture wire. Even the process of removing a syringe from the needle is gonna mess you up. So I typically will just stick it without a syringe on there and try to get that flash that I need. Just a style point, but it really helps when you've got maybe 1 or 2 shots at it before you develop a hematoma that just renders that vessel completely inaccessible.
Those are some great tips and tricks. So thank you. Let's pivot now that we have IV access. Let's talk about resuscitation. And so I want to hit on a couple of things. I want to talk about damage control resuscitation in children. I want to talk about whole blood versus component therapy. And then I want to talk about adjuncts, specifically TXA, calcium, vasopressors. Where do we stand on those things? So let's go through them individually. What about damage control resuscitation?
I think if you're downrange, you're going to have whole blood, right? If that's what we're stocking, and that's low titer O whole blood, even if it's Rh positive, give it, right? We don't have the results of the big MEDIC-2 study, which is something that's being run out of Pittsburgh by Phil Spinella, a pediatric intensivist in the Air Force, with did a ton of work in the resuscitation space, and still is doing that. We don't have those results yet, but I think there's enough indicators that giving the whole blood, giving them back what they lost, is really important. That would be my first comment. And then with respect to TXA, I'll defer to Dr. Martin because he wrote the paper on TXA in children downrange.
Let me just, before Matt answers that question, so let's talk about the whole blood. So you do a walking blood bank and you have an adult unit. How do you do it? How do you execute the transfusion in the child?
Yeah, so it's not going to, I don't know if it's going to be leuko reduced or not, but in a pinch, you got to do what you got to do. Rh positive, Rh negative doesn't really matter, because the allosensitization issues that are kind of the big boogeyman for whole blood are really, I think, turning out to be less of an issue than we thought, particularly for young women. But start out with 10 to 20 cc's per kilo. And I mean, that's just, when it comes to peds, the numbers you have to remember are the 4-2-1 rule for maintenance fluids. And you have to remember that they have about 80 cc's per kilo of total blood volume, which is helpful when you're in the OR and you're soaking up lap sponges. And that 10 to 20 cc's per kilo in terms of the boluses that you're administering, whether that's crystalloid or hopefully blood in the context of resuscitation. Those are the important things to remember. And the last thing would be, what is hypotension for a child? And generally, it's like meters of mercury plus 2 times their age. So if you're a 3-year-old, 2 times 3 is 6, plus 70 is 76, and that's kind of your borderline low level for hypotension, to understand that in the context of kids. So that would be my just general principles in terms of resuscitation, the quick and dirty, the things that I think will get you by.
Yeah, I think just a general thing is all the damage control stuff we've learned in adults, just apply the same thing to kids. I think the most important thing, especially for adult trauma surgeons, that we very quickly lose track of is the blood volume of that child. And we finish our case and the floor is covered with blood and we're like, okay, high-fiving. Just remember, the smaller the kid, the lower that blood volume is, down to, a 1-month-old has about a can of Coke is their entire blood volume. So you can have a couple lap sponges full and some on the floor, and that's exsanguination that we often, doesn't often key us off as adult surgeons as this is large volume blood loss. So it's just understanding that much less tolerance for how much bleeding you're having. 40 mLs per kg is about half their blood volume, right? So 10 to 20 mLs per kg is usually about what you'll start off with for giving them blood products. Yeah, TXA, we did the PED-TRACK study in combat pediatric patients. We found a benefit of TXA, retrospective data, no signal of harm. So I would give it liberally, just like we do for adults, and standard dose. And I think even the TCCC guidelines for adults have gone to single dose pre-hospital. I would just do exactly the same thing for a kid.
Exactly. Yeah, 25 mg per kg, right, is up to 2 grams is what we would do for kids. And that's based on some of the stuff with MADIC too. Like, why reinvent the wheel? A lot of smart people have spent a lot of time thinking about this. But yeah, I think that the MADIC 2 trial and its its investigation of TXA and its benefits was really influenced by the PEDS-TRACK studies that were done in Iraq and Afghanistan by Martin and Eckert. That's really important.
Eckert and
Historical
Martin.
context.
Eckert and
Eckert.
make sure you have Eckert first.
Okay. Yeah, he goes first.
And then the only other thing I'd say is remember that kids probably are also more susceptible to circulatory overload from over resuscitation. So you also want to be careful about that. Once you've hit your resuscitation goals, you don't want to be flooding them with a lot more blood products. And again, we're used to hanging a unit and then another unit and then another unit. And people might not be thinking this many cc's per kilogram and not run that whole unit or two of blood.
That's right. And a lot of times it's delivered, especially in smaller children, through a syringe, just literally pulling it back. You have to be careful about how hard you do that to prevent lysis of those RBCs. Backing up just 10,000-foot view on this whole scenario. If you are hypotensive as a child, a school-age child or even younger, or adolescent too, then you are way behind. That's children and little adults. That adage works up to a point. The reality is that the child's compensatory mechanisms with heart rate and vascular tone are so robust that until you get to the very, very end of their physiologic reserve, they're going to maintain their pressure, and you're going to have a false sense of security. I think about you get there and you just fall off. Barbara Gaines is a sort of a luminary in the blood space and in resuscitation and peds trauma. And her comment that she made one time really resonates. Like, if you are hypertensive in a hemorrhagic, trauma patient that's a child, you are way behind. And that needs to, not just a little bit behind and like, let's get on it, but you are about to get bradycardic and arrest. And so that's something that I think, along with the nasogastric tube, little pearl is a big thing to leave, is that hypotensive children from hemorrhagic shock are about to arrest.
Can you guys both comment on hypothermia management for the kids, especially in a role two setting?
Yeah, avoid it.
Just like adults, they will get hypothermic much faster, right? They have increased body surface area, so you want to keep them warm even when, you take all the blankets off and have them exposed and then prep and take 15 minutes. You want to keep them warm, you want to turn up the room, you want to use your HPMK, your hypothermia prevention management kit or whatever you have at your facility. If you have any way of doing forced air, warm blanket or bear hugger, do that aggressively. These kids will get hypothermic very quick.
Yeah, I think the other thing is having a belly compartment open is just going to accelerate that so fast. And one of the things that we will routinely do, and this is just a little hack, is anesthesiologists will take a bag, literally a plastic bag after the child's intubated, and put it over their head. It's like, what are you doing? You're going to suffocate this kid, but they're intubated, and trying to minimize any heat loss through their head, especially for toddlers and these younger children that have a disproportionately large head to the relative body surface area. And then using a lot of Ioban to make sure that we can keep them as dry as possible. You don't get a lot of fluids that are dripping down around the child that they're sitting in it, because that'll get them really cold as well. So we just try to do stuff like that, common sense stuff to avoid that. And anything you can do from an active warming standpoint is great. Just downrange, your options are probably limited.
And then don't forget about transport. Transport, it is cold on those helicopters. And if you don't have that child packaged up completely, the tinfoil hat entirely covered, earplugs, eye protection, they will get cold on transport too.
Yeah, we use as the transport, even from the OR to the ICU in our hospital. We have it basically looks like a giant hand warmer. It's a little bit fluffy, but it's one of those, the kind of you'd put in your mittens when you're going skiing. Those kinds of things, thinking outside the box and employing those kinds of things, hand warmers can be really helpful.
All right, switching gears here just for a second. We've talked about resuscitation. I wanted to get a couple thoughts on the actual surgical portion of this. So, when you're approaching surgical hemorrhage control in pediatrics and trauma setting, how does age and anatomy play a role in determining, what incision do I make? Is it a transverse laparotomy? Is it a midline laparotomy? Is there an age cutoff? I remember doing this in residency as a pediatric surgery resident. But can you kind of comment on the size of the patient and how that plays a role?
I'll go first because my answer is the shortest. I'm an adult surgeon. Don't deviate from what you know. I'm making a midline laparotomy if it's a laparotomy. But Luke can expand on that because I know there's certainly other options, but don't go way out of your comfort zone for a kid that's dying of hemorrhage.
Yeah, I think yes to that, with the one exception that, for anything less than probably 24 months, if you're over 24 months, that makes a lot of sense. I do think that your exposure, the expansile nature of a transverse laparotomy, and some of these kids that have a Buddha belly that's almost like a basketball, you can see everything really well, and particularly expose the liver and other things like that bleed with a transverse laparotomy. So I think your general cutoff is if they're less than 2 years old, go for transverse. And it's not hard. I mean, you just have to make sure you ligate the umbilical vein remnant. But that would be my thing. And to be honest, like, this is a good question because I still struggle with these tweener kids. What's my best exposure? So it's not necessarily straightforward, but I think a good rule of thumb is if they're under 2 and it seems like they have a round belly, then go for the transverse.
So the other thing I wanted to kind of mention or talk about for a couple minutes was limb salvage. Now, in a deployed setting, kids dying of hemorrhage, I think that the decision for limb salvage or not, or vascular reconstruction, is a tough decision. But how do you draw the line in the sand with kids?
Yeah, I'd say in fact, I can't even remember making this decision of we can't get hemorrhage control. We have to amputate because we can't get hemorrhage control of an extremity, right? You can always get hemorrhage control of an extremity. So it's very rare you're kind of making this decision of I need to amputate because the patient's dying from bleeding that I couldn't control in that extremity. The decisions are usually, is this reconstructible? Is this something I can fix? And what's their long-term outcome going to be with a semi-functional or non-functional limb versus an amputation? Now, the thing to remember, which is counterintuitive, is like for adults, we would often be more aggressive at limb salvage for local nationals and more aggressive with early amputation for our US service members or NATO allies. And that's because they're going to come back to the US and get a well fitted modern prosthetic. And this local national who now has an amputation and they're not going to get a prosthetic and they're going to be an outcast from society. They're not going to be able to work. So many times they're better with a partially functioning or even a non-functioning limb, but still having the limb. And I think those same things apply to pediatric patients. Local, national kids, I would definitely try to avoid amputation early and opt for whatever you can do for limb salvage, and then you can make that decision later. I think probably the biggest difference with adults is the management of vascular injuries. And the smaller you get, the less reconstructible those vessels are. And sometimes in those settings, you have no option but to ligate. But actually, oftentimes they'll tolerate that ligation. So, I'll let Luke take it from there.
No, I think you've hit the nail on the head, said everything I would say, which is you can get away with a lot more than you think in terms of ligation because of collateral flow in these kids. And we know that, at least from the civilian literature, because of iatrogenic injuries surrounding vascular access. You bugger up a femoral vein and it turns out to be okay because they can collateralize. So there's that, right? I think that to Dr. Martin's comments, you've presented a scenario earlier where we're in Eastern Europe, and that's very different than being in Iraq or Afghanistan. And I certainly echo his comments about the calculus, the mental math about what is going to be best for that patient long term is highly cultural. It depends highly on cultural context. It is contextual for sure. And so that's where really relying on a lot of your host national partners that understand the culture and the context to help make those decisions, I think is important. I mean, kids are often resilient though. Their ability to navigate life as an amputee with or without a prosthesis is pretty amazing. So it goes both ways, but I think that's a situation in which I would really rely on host national partners in the healthcare realm to help me understand the clinical context or the cultural context. And it's a tough question.
These have been some great points and a great discussion. Let's take a higher 30,000-foot view. For surgeons who have yet to deploy or about to deploy, what should they be doing to prepare to take care of injured children or care for sick children downrange?
I think in terms of just being able to access materials, there's a lot of stuff online. The Pediatric Trauma Society does an excellent job. They partner with the AAST and with East to produce guidelines for best practice in the care of an injured child. Some of that stuff is not going to be relevant in an austere or deployed environment because of resources, et cetera, but at least it's a good starting point. So I definitely would point people, if you know you're going down range and you want to kind of at least have a collection of resources in your back pocket, certainly the Pediatric Trauma Society website, as well as East guidelines. And I think more than anything, having a good head on your shoulders, maybe planning with respect to grab a Broslow tape, grab some other stuff that you might need in your hospital that you think would be appropriate for pediatric care, and just have that around. But being intentional about that, I think, and listening to things like this and getting as much content as you can, those are all important aspects of getting ready. Being a good general surgeon is going to make you a good surgeon in a pinch to take care of a child.
Yeah, and I'd say that there's also a pediatric module on the KSA modules. So you certainly can go through that. And then utilize your mentors. I reached back to Ken Azaro, who was my program director as a pediatric surgeon, multiple times with kids that I wasn't sure what to do with. So usually you have good communication, at least email, often phone. So don't think it starts and ends with you. You have resources available to you, and I have yet to ever reach back to anyone and have them say, "Oh, sorry, I can't help you." Everyone's always very willing. They're willing to help out with that kind of stuff. And then, like Luke said, bringing pediatric supplies, and the best is if you can reach out to the people who are there already and that you're replacing or joining, and saying, "Hey, what are you missing? What are the big gaps?" And usually they'll send you a list, and you'll carry a duffel bag full of stuff into theater. And that's how, over 2 decades, we built up, pretty extensive pediatric supplies in Iraq and Afghanistan.
I think past that too, just one other point to throw out there is understand the rules of engagement and your DCSS and what kinds of things are going to be no-go areas and what they're going to say no to and yes to, and just have a general understanding, because I think more than, I mean, some of the things I think back on and the faces I see are the children that we had to say no to, or we had to stop in terms of their care because of the extent of injuries or local constraints and things like that. So having a plan and initiating that conversation before you ever have that patient in your resus bay is really important.
Well, Dr. Martin, Dr. Neff, thank you so much for joining us today. This has really been a great episode of some really great techniques and pearls for junior surgeons and seasoned surgeons heading to the battlefield. Everyone, thank you for joining us on Frontline Surgery, Mastering Military Trauma Care. We hope today's discussion gave you practical tools and perspective as you prepare for your role on the front lines. Until next time, stay sharp, stay ready.
Thank you for tuning into this episode of Frontline Surgery. We hope today's discussion has provided valuable insights into military trauma care.
Be sure to join us next time for more expert perspectives and battlefield-ready knowledge. Until then, stay ready.